autoimmune encephalitis. So the question is there needs to be a workup? And if yes, what workup should be needed for a 10-year-old patient with acute psychosis, such as MRI, EEG, lumbar puncture, etc.? You're muted. Sorry, Dr. Rush.
Of course I was. I can tell you what we have done at our program at University of Cincinnati Medical Center, which is called the FEELS first episode in engagement and treatment. We have a first episode psychosis or first episode mania protocol, which includes the ordering of psychological testing, MRI, blood testing, including the Mayo Clinic's autoimmune encephalitis panel or encephalopathy panel. But then some of the tests that are also kind of looking for zebra diagnoses, like copper levels for Wilson's disease. Some of our attendings like to order, excuse me, the word is skipping my mind right now. Those are the basic labs that I would order, though. I think the encephalopathy panel is the most important. The blood panel, I have been told by neurologists who treat A here in Cincinnati, is a good first screen and should be followed up with CSF if negative. Although oftentimes, per my understanding, even if an encephalopathy panel is negative, if the clinical situation is most significant, consistent with autoimmune encephalitis, treatment should pursue.
Mm-hmm. Thank you. So next is Dr. Deng. Can second-generation antipsychotics and benzodiazepines cause cognitive blunting in patients with pre-existing cognitive problems?
I think that's a great question. And I would say there's kind of two parts to that answer. I think maybe there's one question first, which is, during the clinical evolution of autoimmune encephalitis, is there kind of an impact on the presentation as a result of these medications? And then secondly, is there maybe long-term sequelae that is caused in part by the use of some of these medications? Let me answer these separately because I think that the answers are different. Definitely in terms of the clinical evolution, I would say that there is one of the very tricky aspects of caring for these behavioral problems in patients with autoimmune encephalitis is that there is a tremendous amount of effect both in antipsychotic use and benzodiazepines. In particular, I think one of the things I want to focus on in my talk is that for certain types of autoimmune encephalitis, in particular in NMDA, there is a real question of whether or not antipsychotic use is safe during the initial part of treatment. So I think that a lot of the kind of, dysautonomia features, a lot of the kind of affective changes, catatonia, there's a real question of whether or not these medications can also play a role in contributing to the overall presentation. In terms of long-term sequelae, I think this question is a little bit trickier, and I would say that we don't have a lot of data in this area. We don't have a lot of hard data to answer this question. Definitely, I think that my personal clinical impression is that because some of these medications are working at kind of downstream modulation from the kind of area of initial pathophysiological mechanism, my belief is that in the long term that I think the larger cognitive sequelae are driven by the underlying process, not by medications. And in fact, I do think that there is some very limited research that suggests that benzodiazepines can be productive, at least in animal models. But again, I think to answer this question will require an amount of data that we don't have, unfortunately, yet.
Mm-hmm. All right. Thank you. To Dr. Vernino, what is the recommended, I think this is routine clinical and laboratory testing conducted for paraneoplastic neuropathy, especially with so many novel biomarkers that are being discovered?
Sure. I think the one challenge is that the most common paraneoplastic neuropathy disorder is a rather run-of-the-mill axonal neuropathy, which can be due to a lot of different things. And I don't think our current serological testing is very sensitive. It can be quite specific. So, the anti-Hu antibody or one of the others, strongly suggestive of cancer. So if a paraneoplastic syndrome is suggested or is suspected in the case of a peripheral neuropathy, then the standard routine paraneoplastic antibody panel should include the anti-Hu antibody, the CRIMP5 or CV2 antibody as the main ones. But most of these are common panels that include the whole gamut of things. But I guess the point is that you can't really rule out the paraneoplastic cause in that setting because many of the cases are antibody negative. And if the suspicion is high enough, there's cancer risk factors, a cancer screen is quite appropriate in addition to the serological testing.
Mm-hmm. Awesome. Thank you. So now coming back to Dr. Gorman, do you observe major differences between the titers and symptoms between what you see in adults versus what you see in pediatrics?
Yeah, so one caveat, I only see kids in my practice. That said, in terms of titers and in pediatric patients, the two most common forms of autoimmune encephalitis are anti-NMDA receptor and anti-MOG. So in anti-NMDA receptor encephalitis, there has been some papers published looking at the correlation of titers, particularly with relapse. The challenge there is that there is some correlation, but it's not perfect. And the correlation is better in the spinal fluid than in the serum, which makes it challenging in terms of something to follow serially. In terms of anti-MOG, there is, I think, pretty clear evidence now that the higher the titer, the more confident you can be in the diagnosis. One paper that was published, titers of 1 in 1,000 were considered 100% specific, whereas titers of 1 to 40 were around 50% specific. So with MOG, I think you always have to put it in a clinical context along with the titer.
Mm-hmm. Awesome. Thank you. So coming back to you, Dr. Van Mater, how often do you diagnose autoimmune encephalitis in the outpatient versus in hospital setting? Have you made the autoimmune encephalitis diagnosis in patients who are presenting late, who have responded to immunotherapies initiated after or greater than 2 years after symptom onset?
So we do make diagnosis of autoimmune encephalitis in the outpatient setting. Those are going to usually be kids, a pediatric rheumatologist, so similar to Dr. Gorman, just see kids. These are going to be kids who usually have more of a slow onset, so not that really abrupt overnight encephalopathy or seizures that often will have kids admitted pretty quickly, but usually more of a slow build in symptoms. Still can be quite dramatic. That may include cognitive differences as well as some of the psychiatric symptoms that may take it a little bit longer for people to realize fully what's going on. So that definitely can be seen in an outpatient setting. The trickier part, I would say to the other, so most of our patients are diagnosed inpatient because most kids present with a little bit more of an acute onset, and most of our NMDAs, if not all of our NMDA patients, have been diagnosed inpatient. Our GAD encephalitis kids, those are more likely to present as an outpatient evaluation. It's about half and half of the kids that we've seen because they do tend to have a more insidious onset in our experience anyway. So again, some of this varies by which antibody. One thing I did want to mention with GAD antibody that I forgot when you asked my first question is GAD antibodies are really common, especially low titers. So a serum GAD antibody should not make a diagnosis of autoimmune encephalitis, in my opinion. I'd be curious if the panelists have another thought on that. You really are looking for GAD titers in the CSF to help really confirm GAD encephalitis. That's probably one of the most common email questions I get from providers and patients is what to make of that serum. And then to the question of treatment long-term, we definitely have seen patients who have some response after having long duration of symptoms from autoimmune encephalitis. I will tell you they don't tend to have as robust a response as patients who get diagnosed earlier, and I think that the literature supports that conclusion as well. And really what you're looking for to help differentiate if they're likely to see a response to immunotherapy or not is if you see signs of active inflammation. So do they have the white cells in their CSF? Are they making extra antibodies in the CSF? Things that can tell you there's an active inflammatory process going on as opposed to something that's kind of a past process that has left more residual injury changes.
Mm-hmm. Thank you. Dr. Rush, the next question for you. Are there any antipsychotropic medications that you find helpful for improving cognitive symptoms past the acute phase in autoimmune encephalitis? Ritalin or Strattera?
So I like the question. The medications Ritalin or Strattera are not ones that I personally would start in patients with autoimmune encephalitis, although you have to consider as a psychiatrist, if I am seeing somebody with AE, they have psychiatric manifestations, and oftentimes that includes psychosis. And so using any medications that increase dopamine, which includes the stimulants that are used in ADHD, methylphenidate or Ritalin, Adderall, or amphetamine, those run the risk of increasing your psychosis. I prefer to at least start with medications that were initially developed for hypersomnolence. And those include modafinil or Provigil and armodafinil or Nuvigil. What I always do, however, is get a neuropsychiatric evaluation done so that I have an exact understanding of what the cognitive deficits are. Unfortunately, within our department, we have a cognitive disability center, and I have a colleague who does the testing for me, and a lot of facilities, neurology departments will have that kind of testing. Mm-hmm. So first is to understand what the specific deficits are, because then that may also guide how you would choose to treat it if you do.
Mm-hmm. Awesome. Thank you so much. Dr. Deng, probably this is a question for both the psychiatrists on this panel. So what are the clinical difficulties as a psychiatrist you have observed in the management of autoimmune encephalitis patients? How do you manage side effects coming from antipsychotics in autoimmune encephalitis? So I'll start with Dr. Deng, and then I'll proceed with Dr. Rush.
I think that a lot of the questions this panel has been fielding really kind of get at this answer. I think there are a couple of areas that psychiatrists are really faced with tremendous challenge in autoimmune encephalitis. The first one is how to make the diagnosis, especially early on in the diagnosis when maybe patients' predominant or only manifestations might be psychiatric. So I think that's a tremendous challenge. And there's been a great deal of work in this area, understandably. I would say the other clinical challenges that we see are in managing how to best manage cognition and agitation without causing any potential risk or harm during the acute phase of illness. In particular, there have been a lot of questions about the risk of NMS with antipsychotic use. So that's another question that I think is unresolved. And I tried to talk a little bit about that in my discussion of why that might be. And, that while there's great concern for it, that the risk seems to be primarily in potential NMS before any kind of immunomodulatory treatment. And then I think there's two other kind of equally important long-term challenges. Again, I would welcome any input. I'd be interested in the other panelists' opinions about this. But I think we need more research and more work into whether or not early kinds of treatments like ECT might be beneficial for long-term cognitive outcome. And I think in general, we need more research into long-term cognitive outcome. I think one of the things that we've certainly seen at Mount Sinai are a subset of patients who have these kind of long-term motivation and affective sequelae, for which I think there's just not a lot, unfortunately, not a lot of tools that we can offer.
And Dr. Rush, would you like to comment as well?
Sure. I will speak from my experience with patients with AE. And much of the time I'm being referred for psychotic or symptoms that are consistent with the kind of manic episodes you may see in bipolar disorder plus psychosis or catatonia. In truth, my intent and the idea is that I actually am going to treat them similarly to the way I would treat schizophrenia or bipolar disorder or catatonia in any other circumstance, except for one specific caveat, which is that patients with autoimmune encephalitis are at a much higher risk to develop neuromuscular side effects from the dopamine blocking activity of some antipsychotics. And so when choosing an antipsychotic, I am almost always moving first to a medication called clozapine, which does not or very minimally affects dopamine receptors, and also is a glutamate agonist, which needs more study, but perhaps has an effect there. And alternatively, Seroquel or quetiapine as an antipsychotic, because it doesn't really affect dopamine very much. Side effects are very difficult. And I don't know that there's enough time here to get into the side effects of medications. There are some very good books on managing side effects on psychiatric medications, especially clozapine. And again, a lot of patients with AE with psychotic symptoms are on clozapine. One of my patients' mothers actually gave me a book on the side effects of clozapine that I did not have before, and was a guide that to this day I use to teach residents. I only wish that I could remember the name. I am just getting over COVID, and so my ability to remember that is a little bit short.
We can take that offline as well, Dr. Rush. Once you have the book's name, we'll be happy to share it with our audience out there. So thank you. And then coming to Dr. Bernino, this came in towards the end of your talk, so I just wanted to add this. For anti-ganglioside antibodies, is it relevant to screen for both IgG and IgM antibodies or just one of them?
It is relevant to screen for both. Certain ganglioside antibodies, such as anti-MAG, for example, the IgM is much more relevant to the neuromuscular presentation, and in others it's IgG. So, frankly, I find it hard to remember all of that. So I depend on the laboratory to interpret the IgG and IgM of the different species of gangliosides. But yes, there are some differences in the different syndromes that are associated with those. And that's kind of an evolving area. There's some classic ones, like the GQ1B antibodies that are IgG associated with Miller-Fisher syndrome that have been known for a long time. But many of the others are somewhat variable in their clinical associations, as well as the IgM versus IgG types.
Awesome. Thank you. And then coming back to Dr. Gorman, so is there any clinical difference between MOG-associated disease in pediatrics versus acute disseminated encephalomyelitis?
Sure. Yeah, so I think starting from the clinical diagnosis of ADEM, so ADEM or acute disseminated encephalomyelitis is really a clinical radiographic diagnosis, which must include the presence of mental status changes, multifocal symptoms, and then typically has multifocal white matter lesions. There are published diagnostic criteria that are expert consensus-derived diagnostic criteria for ADEM, which I would encourage providers to follow. If you apply those criteria in a pediatric patient and they meet criteria for ADEM and you send anti-MOG antibodies, about 50% of them will be positive for anti-MOG antibodies. On the flip side, if you take all first-time presentations of pediatric demyelination, about 30 to 40% will have anti-MOG antibodies, and the percentage depends on what the clinical phenotype is. So ADEM is the phenotype that has the highest percentage of anti-MOG positivity, but you could also have optic neuritis or transverse myelitis and have anti-MOG antibodies.
Mm-hmm. Thank you. Dr. Van Mater, if IVIG or plasmapheresis was done in emergency before antibody testing, is it still relevant to do it after treatment? If yes, after which period do you recommend testing for these antibodies?
I'm going to take them one at a time. We'll do IVIG first because I think about them a little differently. So IVIG, you're giving pooled antibodies from donors. So it is very possible that you can have a false positive if a donor happened to have an antibody that was positive. So this is going to be for antibodies that are more common in the general population. You're going to have to worry about this. So in general, we think about if you get the antibody testing after IVIG and it's negative, you very likely do not have any of those antibodies positive. If you have testing that's positive, especially at a lower titer, it gets a little bit more complicated to know if that's your antibody or from the IVIG you received. And so then we recommend checking it, especially if there's an antibody, there's titer available so that you can see, is that titer going down as you're further out from your IVIG? This will be complicated if you're continuing treatment or not. So really also looking at, does your clinical phenotype fit with the antibody that was positive in your testing? So that's really important that those correlate. And then our AI or allergy immunology colleagues would recommend repeating at 6 months after IVIG, somewhere between 5 to 6 months, as you should have cleared most of that IVIG that you were given if you want to know for sure if it was a true or a false positive. Plasmapheresis, plasma exchange, a little more complicated because you're filtering off antibodies. And so especially if you had a low titer antibody, that could be gone in the very acute period, although I would question if anybody here is on the panel has seen it truly go negative in somebody you thought had autoimmune encephalitis. Usually we're able to send those panels before we have someone to get plasma exchange or plasmapheresis, especially in pediatrics because it's much more invasive getting central lines and things in kids. So hopefully that will have been sent beforehand. If not, you will start to make those antibodies if you have an ongoing autoimmune process where you're going to continue to form those antibodies. So we could repeat those usually 4 weeks later and expect if that was causing your symptoms and you have ongoing symptoms that we should be able to detect that antibody coming back. But if those antibodies, like I said, after IVIG are negative, it's unlikely that you do not have to repeat it in the future because it's already negative.
Thank you so much. So the next question is Dr. Rush. Again, I will come back to also Dr. Dengs to see if both of you can chime in on this. What are the drugs or treatments that can help with cognitive decline? There's a second part to this question. Is there a drug that can help protect the brain from the onslaught of this disorder?
So thank you for that question. It's a little bit different than the previous question about cognitive disorders in the sense that I think I'll focus my answer on preserving brain function. And there are some simple things that can be done without the prescription of a physician. All of my patients are taking N-acetylcysteine, which is a very powerful antioxidant, taking about 1,200 milligrams twice a day, which has evidence to be used in schizophrenia to prevent the neurotoxic effects of psychosis. So psychosis or psychotic symptoms can be toxic to our neurons. There is also evidence that medications that increase levels of something called brain-derived neurotrophic factor can help be neuroprotective and protect our brains in general. And so if the occasion is appropriate, if the symptoms call for it, for example, in a patient who appears maybe manic because of encephalitis, I may choose lithium because it increases brain-derived neurotrophic factors maybe more than some of the other medications that we use in psychiatry. There is limited study of using medications that are also used in Alzheimer's dementia or any other kind of dementia, such as Namenda or Aricept. I personally don't have experience with those because most of my patients are already burdened with side effects, and I am concerned about the side effects that may come from that. I'd be interested to hear from Dr. Dang his thoughts on either of those medications as well.
Mm-hmm. Dr. Dang? You're muted.
Yes, I certainly agree with Dr. Rush and echo what he's saying. I think I think that question about the anticholinergic esterase medications that are traditionally used in dementia, that is a great question, and I think we don't really have. I'm sure, as Dr. Rush would agree, I don't think we have a lot of hard data to kind of know whether or not it will have long-term outcomes effect. I also wanted to kind of, I'm not sure if the individual asking the question was meaning this in particular, but I certainly do want to say that I think a lot of there right now is there's much more interest and much more there's a great research push into the underpinnings of the process in general and how we can try to reduce, how we can first identify who might be more at risk for long-term significant morbidity and how we can prevent that. But I think that a lot of the traditional tools that we are using for kind of cognitive or affective treatment, so to speak, my personal opinion is that they are more of downstream modulators rather than, in this case, I think we're dealing with something that's affecting the receptor at an upstream site.
Thank you. So I'm going to take one last question for Dr. Bernino, and then I have to close this session so that everybody can move to the next panel. Dr. Bernino, can GBS convert to CIDP?
I think that's just really a definition question. CIDP has to start sometime. So there are patients who present with a more acute presentation, which then persists in a continuous state instead of improving. And then at some point, depending on your definition, symptoms continue to progress over 6 weeks. You could call it CIDP. The clinical diagnostic and electrodiagnostic features are very similar. And so it's really just about, is it a monophasic severe course that consistent with GBS or a more chronic demyelinating neuropathy that would be called CIDP? And that's really what makes the difference and what guides whether the treatment needs to be ongoing or treating the acute illness with an expectation of remission in the case of GBS.
Mm-hmm. Thank you so much. So with that, I would like to thank all the speakers who are here today for your presentation, as well as for answering all the questions live. I understand that there are a lot more questions, but we will be relaying them to the speakers via email to get their responses in the next couple of days. In the meantime, for the participants who are listening, please close this session and you can go back to the auditorium to join the panel 3 discussion or the panel 3 presentations. Additionally, if you're interested in any PACE credits